In this video, I will discuss chronic lymphocytic leukemia (CLL). So, CLL is a chronic lymphoproliferative disorder that is characterized by the accumulation of mature, but these mature cells are dysfunctional B lymphocytes. So, it is a chronic lymphoproliferative disorder that is characterized by accumulation of these mature but dysfunctional B lymphocytes. Epidemiology. It is the most common leukemia in adults and median age is almost 70 years. So median age is almost 70 years and it is most common leukemia in adults, especially in the western countries. Pathophysiology. There is clonal proliferation of the B cells and these B cells are CD5 positive, CD19 positive and CD23 positive. These markers are positive for CLL and we will discuss in immunophenotyping for when we will diagnose the CLL. There is defective apoptosis and it leads to accumulation of the B lymphocytes in the blood inside the bone marrow and inside the lymph nodes, leading to splenomegaly and lymphadenopathy. There are genetic abnormalities like deletion of 13q, that is long arm, and deletion of 17p short arm, trisomy 12 and TP53 mutations. So these mutations can be seen. These are genetic abnormalities. When there is 13q deletion, it has good prognosis. When there is 17p deletion, there is worse prognosis. So these should be remembered. Del 13q, good prognosis, while del 17p, worse prognosis. What are the features with which patients present? Mostly patients are asymptomatic, but the symptoms that can occur are fatigue due to anemia, night sweats, weight loss and fever. These are B symptoms. Patient may have lymphadenopathy, splenomegaly and hepatomegaly. Patient may have recurrent infections because of hypogammaglobulinemia, because B cells are dysfunctional, although they are mature but dysfunctional. Therefore, there is hypogammaglobulinemia leading to recurrent infections. There is also autoimmune hemolytic anemia or immune thrombocytopenia seen in this CLL, chronic lymphocytic leukemia. How will you diagnose this condition? First, you will do CBC. In the absence of any viral infection, you will see absolute lymphocytosis more than 5000 per mcl. Absolute lymphocytosis more than 5000 per mcl. On peripheral smear, you will see smudge cells. Smudge cells are actually formed due to destruction of the lymphocytes when slide is prepared. So it is due to destruction of the lymphocytes when slide is prepared. Smudge cells. Flow cytometry tells us about CD5 positivity, CD19 positivity and CD23 positivity. Bone marrow biopsy is not always required and it is mostly not needed. And some other techniques like cytogenetics, FISH analysis are also done for prognosis. But the important one is flow cytometry that identifies CD5 positive, CD19 positive and CD23 positive. What are the staging systems used for this? The most common one is Rye staging system. Stage 0 is when there is only lymphocytosis. Stage 1, when there is lymphocytosis plus lymphadenopathy. Stage 2 is when there is splenomegaly and hepatomegaly also. And stage 3, anemia. Stage 4, thrombocytopenia. So it has 5 stages, but first stage starts with stage 0. So stage 0 is lymphocytosis, stage 1 lymphadenopathy, stage 2 splenomegaly and hepatomegaly, stage 3 anemia and stage 4 thrombocytopenia. This Bennett staging, that is European system, is not widely used. Management. Wait and watch policy is adopted for asymptomatic early stage disease, but when there are some indications for treatment, like patient has cytopenias or patient has more than 10 centimeters lymphadenopathy or patient has more than 6 centimeters splenomegaly, or if patient has lymphocytes doubling count over less than 6 months, then we will start treatment. First line therapy nowadays is tyrosine kinase inhibitors, ibrutinib or acalabrutinib. Other agents like venetoclax plus minus anti-CD20 antibody like rituximab or obinutuzumab can be used. Previously, FCR, that is fludarabine, cyclophosphamide and rituximab was used as first line. It is now in young fit patients but is less common now. Previously it was first line, but now ibrutinib and acalabrutinib plus venetoclax and rituximab, these agents are used as first line, while FCR, fludarabine, cyclophosphamide and rituximab are used second line or in young fit patients. Supportive care. IVIG is also given because patient is at risk for recurrent infections. So IVIG is given to prevent these infections. Furthermore, for fludarabine, when you will start this, there is risk of pneumocystis jirovecii with this fludarabine. So you have to give cotrimoxazole for treatment of the pneumocystis jirovecii. So this is all about chronic lymphocytic leukemia.